Well, good afternoon. I would just like to welcome everybody on behalf of the team of people here today. I'm Clive Weir, I'm Chairman of Essex Care Association. Some of you will know me if you've been to one of our conferences, and I hope we'll be able to meet again soon like that. But in the meantime, we have video. I have to say, it does feel good to be coming together after what has been months of extremely challenging times. So many people have died. The stress of keeping people safe, interpreting government policy, dealing with discharge teams who give false or misleading details about patients because there is pressure to discharge. We've been threatened with safeguarding because we insisted upon a test being carried out prior to discharge. There is no doubt that we have been badly treated, but at last the media has presented our part of the story. However, I would also like to say that I feel that Essex County Council members and officers have sincerely appreciated our predicament, and it has felt like one team working together. Although we'll always have a different agenda when it comes to demanding that they pay fees which genuinely cover the cost of care. So going forward, we all need to work together if we are going to see this pandemic controlled. We must pressure our MPs to deliver a white paper immediately and recognise the care sector as equal partners with the NHS. We must also seek to obtain additional support funds to keep us viable in the short term. And ECA, ECC and the NHS need to work together in pursuit of these goals. And it's within that framework that I'm pleased to introduce our speakers today. But before I do that, let me hand you over to Simon, who is our Development Director of ECA.
Thank you, Clive. Welcome, everybody. Just a reminder, if you have your camera switched on, everybody can see you. That's fine, just be aware of it. But also feel free if you want to switch your camera off. And we would encourage you to keep on mute as far as possible. I'm going to talk briefly about the online survey that some of you very kindly responded to, asking you about your experiences during COVID and looking forward a bit more from that. So first of all, so we did have a relatively small sample responding, which was a little bit disappointing as it was quite a short survey, but just a health warning on that. We will publish it all on the ECA website after this event, but here's some highlights. The overall support that people had during the pandemic, and this is prior to the slide you're just seeing, the majority of people reported they were very happy or okay with the support. Similarly, when we asked about communications between them and statutory services, overall, the majority were very happy or okay. Not to suggest there aren't areas for improvement, but in general, very positive. When we asked about their biggest challenges, unsurprisingly, PPE was top of the list, and then a fairly even split against a number of issues there. Not sure if you can read that, but staff shortages were 15%. Accessing to testing more recently, 11%, recruitment, 11%. Interestingly, nobody identified infection control as a problem. If we could have the next slide, please. What else would have helped and what would you have liked seeing put in place? So agreed discharge protocols was the clear winner, perhaps linking back to one of Clive's comments. Nearly a quarter of people asked for that. About a fifth of people said that a phone helpline would have been helpful, and receiving additional funding more quickly was something that 15% of people mentioned. And I'm sure we'll be coming back to some of these issues as our various speakers address local and national concerns. We could go to the next slide, please. Key issues that we need to address now, clear and consistent guidance across health and social care, again, possibly linked to PPE, I know there was a lot of anxiety about guidance coming from different sources and different times, and people trying to decide which was the definitive source and how they could do the best thing, basically. Close behind that, about 15% people said that joint work with health should be addressed now, and equal to that was workforce well-being. Obviously, people have been on the front line. Some of them have very traumatic experiences, unfortunately, so we are very mindful of the toll that that's taken. And then recruitment and retention was not far behind that. If you could go to the next slide, please. So how would you like to engage with ECC over the next few months? We gave people a number of options. The vast majority of people said that they would prefer to focus on meetings to do with their own area of service, for example, home care, supported living, etc. Joint work with health was also felt to be extremely important. Geography didn't seem to be too much of a factor, perhaps reflecting the fact that we can do these events, but there was actually little support going forward for whole Essex events. So people are more interested in what's going on for them in their direct area and things that are most relevant. And if we could leave that slide up just for a second. Couple of other points. 90% of people who responded were classed as small to medium providers. Roughly half of the respondents who gave the answers I've just run through were home care. About a third were care homes, and a fifth were supported living. So as I say, I think we'll come back to some of those themes as we go through our discussions and a Q&A later. But in the meantime, I'm going to hand back to Clive to do our next introduction. Clive.
Well, it's with great pleasure that I introduce Melanie Weatherly to you today. You may have heard her name because Melanie was actually mentioned in the New Year's Honours List of 2020. She's been awarded an MBE for her services to social care. She also led the Trusted Assessors Project, which helps people to return home after a hospital stay. It saves the NHS £80,000 a month. She is one of the largest domiciliary care providers in Lincolnshire. She is a fellow of NICE and Skills for Care, chair of Lincolnshire Care Association and co-chair of Care Association Alliance, where I've had the privilege of listening to her at various meetings. We are a national body which represents care providers from the UK. In her spare time, she also represents us with the Department of Health and CQC. So how she finds time to run her own business, I have no idea. But anyway, Melanie, thank you very much for making time to join us, and over to you.
Thank you very much for that introduction, Clive. And I'm only sorry that we didn't actually manage to do this in person before COVID hit. But I'm just going to take a few minutes to look at the COVID-19 experience of the care sector from a national perspective. And nothing that I say in the next few minutes has any reflection on your relationship with Essex County Council, which I know they have been very supportive. I'm actually talking about the whole care sector when I talk about us feeling that we may not have been perhaps quite as well included as we might like to have been. So can I have the next slide, please? So care providers have clearly been on the front line. Were we valued or were we abandoned? In the early days, a lot of care homes didn't wait for guidance or instruction, they closed. And lots of us actually were taken to task for that and told that we were overreacting. NHS hospitals needed to be emptied and care homes were there to take the patients that they needed to discharge. Strangely enough, in these current days, we were actually told that PPE was not needed in care homes and by domiciliary care providers, and we weren't allowed to buy masks because we didn't need them. We had no guidance, we weren't involved in national discussions. It was a very, very dark time, and I know for a lot of providers, sleep was something that didn't come easy at the beginning of the pandemic. As it grew and care home deaths began to be noticed, the world changed. Discharge pathways changed, and surprise, surprise, we were no longer expected to take everybody and anybody with or without a COVID test and with or without COVID symptoms. PPE was not only thought to be a good idea, it was required. The only problem was we couldn't get any, and when we could get it, we probably couldn't afford it. I know I had several weeks where I don't think I'd ever thought about anything else other than PPE. One weekend back at home, our MP rang us to say, was there any way the care sector could help the acute hospital, because they had a desperate need for gowns. And I turned up with the little boy with the 2 barley loaves and 5 barley loaves and 2 small fishes with my carry bag full of gowns, and came away with 5,000 masks. So we were quite happy with that one. Guidance was updated. Well, it almost felt like daily sometimes. You would go to bed at night thinking you knew what you were doing as a care provider. You opened your inbox in the morning and found out that half of what you were doing was wrong because somebody changed it. But it did start to get better. The local consultations by then in most places were really good, and we started to be included in national consultations. There is a superb task and finish group around PPE, which still meets every Thursday and is one of the most effective hours I spend in the week, because we talk about real issues that providers have, and we can take those to the DHSC and the people who manage the supply chain, and actually get them to understand that it doesn't matter if you've got a supply chain assured for the next 4 months if I actually can't get masks, gloves and aprons for my care provision tomorrow. And we started to be more noticed, more valued. You know, we were included in the clap for the NHS. It then became clap for carers. And one weekend we got really excited because Mr. Hancock was wearing a badge like the one I've got on that said care on it, not NHS, and we thought we'd arrived. I can remember all the emails going around and how excited we all were. We're not at the height of the pandemic anymore. We're in a position where we're being asked to look at recovery, but also preparation. The social care task force is meeting and is coming to the point of actually putting together its proposals for the next 12 months. And we're very lucky that the person who is leading that, David Pearson, who may be known to some of you, his background is as a director of adult social services, and he's taking no prisoners. So I'm really quite excited about seeing what will come from that. We've got local outbreak planning, and we need to make sure as care providers that we understand what that means, what will we be expected to do, how can we help. I hesitate to mention the word testing. When I first started to put these slides together, I thought we'd be testing all staff every week, all residents every 28 days. And then we had the anxiety where we couldn't get the tests and we weren't compliant with national guidance, which was beginning to impact insurance premiums. But again, I think there was a difference last week, because enough of us were able to say to the department, this is causing major problems, you have to do something about it. And last Friday, you've probably seen the letter saying, we have had a problem, we can't deliver this, we're not expecting you to comply with the guidance until early September. It doesn't give us the assurance that our staff and residents have been tested frequently and are kept safe. Absolutely recognise that. But at least it also means that we're not doing the best we can and still being penalised by our insurance premium going up or feeling that we're not complying. So I think there are signs of changing. The care home support review, local authorities were asked to describe to the minister what they'd done to support care homes, and that's now being looked at nationally, and we're being asked to look at it regionally to actually tease out from that what can we do to help, and which local authorities are doing a really good job in one area and how can they help perhaps their local areas, rather than the national bodies telling us all what to do, because that doesn't always work, does it? What might work even in one side of Essex might not work in the other part. So I think there is beginning to be a growing realisation that we're adults and we can make some decisions for ourselves. Have the next slide, please. So I want to look briefly now at the lessons that we've learned Sorry, could we go on to the next slide, please? Thank you. The lessons that we've learned, the things we want to keep, our amazing workforce. They have stepped up to enhance roles, amazing, well, just amazingly. They've taken on jobs that were previously done by visiting professionals to reduce footfall, and actually, in some cases, they're quite good at it. We'd like to keep that one, thank you. They've shown commitment and resilience beyond our wildest dreams. When we first started on this journey, the fear was that we would have no staff, but that's not been the case. And I think we need to recognise and keep recognising that. The peer support from things like Essex Care Association, the support the care associations have been able to give to each other has been amazing. And again, we need to keep hold of that. We've got used to using Zoom, Teams, whatever, and we need to carry on coming together like that, because we can't take the time out to travel up and down the country every week, but we can get on Zoom. Engagements with local authorities, with CCGs, with national bodies. We are becoming more and more recognised as partners, and we want to keep that, please, when we go forward. Next slide, please. Thanks. Some lessons that we've learned, though, things we need to do differently. Funding. We all recognise that funding is a challenge. I think the biggest challenge is that it's always on the last minute. And I share that challenge with, I'm saying to my local authority colleagues, no way do I blame any of you for this. We are all in the same boat. We don't know how much is going to come out of number 11 Downing Street until we're absolutely desperate. And we'd really like that to be different going forward. As we plan going forward, we need to include providers in the start of the planning, not as an assurance at the end. And I do think that message has absolutely got through. As has already been mentioned in your survey, we'd like clarity of guidance, and we'd actually like the guidance to settle for a while. I did wonder at one point whether there were people who were frightened of being furloughed, and therefore whenever the guidance had stopped moving, they had to write some more, or somebody would give them the opportunity to go home. We need some honesty when mistakes were made. We understand that this virus is new. It's something we're learning about all the time. So the guidance that was given in April, with all the best of intentions, may not be fit for purpose anymore. So don't pretend it's the same. Please be honest with us. We're grown-ups, we can cope. Next slide, please. Thank you. So what might the future look like? That's looking back at the past and where we are now. What might the future look like? Residential care. If there's limited visiting and PPE and fear of exposure to viruses, what is the future for residential care? It's a conversation we need to have soon so that we don't get unintended consequences. Enhanced roles. Which bits of our workforce, new roles do we want to keep? Which bits make more sense not to keep anymore? Social care reform. It's happening. Are we part of it? What's going to come out? COVID-19, yes, it probably is here to stay, at least for the foreseeable future. The rest of the world might be going into negative, the lack of lockdown, although even that's changing. But I think the care sector workforce and providers and service users, we're not going back to whatever normal will be anytime soon. And I think that has some consequences for us. What does that do to our staff, particularly for our registered managers? At what point are they reaching the stage where they need a break? And how do we give them that break? Maybe that goes back to something like peer support. I was listening, one of our local medical directors was in the army, and he was saying even in a battle situation, you would not leave people on the front line for as long as we are doing with our staff. But when, even as an acute trust, they've tried to bring them back behind the trenches, as it were, they don't have enough people to do that. And that is something that we're going to have to be wary of as we move into winter. Have we made sure that every single registered manager has had a break? And if not, now is the time to do it, because they're not superhuman. We need to just be mindful of that. And the one thing I haven't mentioned is the tracker. The tracker, I believe, is here to stay. And it isn't just something that somebody invented to make the registered manager's life even more difficult than it normally seems. People do use the information from the tracker at national level, at regional level, and at local level. So a plea, please try to fill it in. If you're not quite sure what it means, some of the questions are confusing. We're hoping they're going to get changed, but it's really important that if you're having difficulties, you let people know. Don't sit there on your own thinking, I should be able to cope. If you can't, if you haven't got PPE, say so. Put the honest answer in the tracker. If you don't know what to do about guidance, pick the phone up, talk to somebody. We are all in this together. And I think one of the things I've learned during this pandemic is that actually the people that we used to think of as the opposition, shall we say, are not. Local government, elected members and officers and local care providers are all in this game for the same outcome, and that is the right quality of care for our citizens. And we've absolutely been all in this together. Next slide, please. Thank you very much for listening. That was just a few reflections on how the COVID-19 situation seems to be playing out from a national perspective.
Well, thank you, Melanie. I'm sure there are going to be those of you who have questions to ask Melanie, and I would ask you just to jot them down, because we will be having time at the end to pick those questions up and hopefully give you a meaningful answer. But now I'd like to welcome Geraldine Rogers. I'm really pleased to welcome her because it is essential, and Melanie made that very clear. It's essential that we work together in the future, and the NHS have for too long kept themselves, I think, to a large extent outside of the discussions that the care sector have been having, certainly between ECA and ECC. But this is getting better, and we welcome Geraldine, and we look forward to hearing what you've got to say. She is Deputy Chief Nurse, Fellow for Older People and Clinical Lead at Basildon and Brentwood CCG. She has been Associate Director of Nursing in the North East London NHS Foundation Trust, where one of her jobs was nurse consultant for frailty and long-term conditions. And she has been an honorary lecturer on older people at the London South Bank University. So Geraldine, you're very welcome, and it's over to you.
Oh, thank you, Clive. And you will find some of the conversations that Melanie and highlights that Melody has spoken about will be reflected in my presentation. It'll be the golden thread of all. So thank you for that kind introduction. As you said, so during COVID, I became the operational lead for care homes for Maiden South Essex. As Melanie described, obviously it was quite a journey during that time. And what we noticed pretty early on, actually, that what was important, especially in Mid and South Essex, where we were working with 3 local health authorities, that was important that we created a platform to share concerns, problems, create solutions as a system to support care homes. And we set about that, doing that really, really quickly. Come the 15th of March, we were doing daily conferences calls. Obviously, the theme at that time was PPE and working and addressing that and how we could mobilise it. So with our colleagues of Moira, Steve Ed, etc., and Simon, of what we needed to do to create that supportive platform so it was where it needed to be. So these were the areas of focus that we looked at the time. So we obviously PPE and infection control. Our infection control team set up a queries line, but we were also, once people contacted on the queries, we were able to ring the care homes and be able to address their needs or concerns accordingly. And that was really, really well received. The next thing what we needed to do, we needed to create a platform where we could actually, in terms of for then and for going forward, create although information governance guidance had changed and that was helpful, but we also needed to help create a better platform, a safer platform, so increase the uptake of NHS Mail. When we started this journey, our percentages were less than 10, and we're now at 83%, which has come a really long way during that time. The next thing was about the bed tracker. Again, that wasn't very well used or implemented, and now so we wanted to focus on that. That was a way of helping, because I think what we'd heard is, because everybody wanted to do good, everybody wanted to look after everybody, but of course what happened then is that poor care homes got saturated with calls, etc. And so what we needed to do was make sure that the bed tracker was utilised, so to prevent all those calls from happening. So that's what we're trying to get our managers to do at the moment as well, because if they can fill in the tracker, actually won't have so much of indent on their time having to get those to do those daily calls. The next thing we looked at wanted to look at was the scope of monitoring deterioration and skills. So looking at that probably enhanced model of care that Melanie talked about in our last call, we set up the care sector tactical group that met up on a daily basis and did extraordinary calls as need be. We then worked with Essex County Council and identified the clinical hubs, which had representatives from health and are obviously a local authority and all other stakeholders from the hospices, etc., looking and rating all the care homes. Then they escalated any problems that they had or that they needed to discuss on that daily care tactical call. We then set up a quality queries line, which was going to be a central point where all the queries would come in from the care home sector, so we did that. And the other thing we needed to look at was training and education. You'll see underneath that picture there of all the people, which was the governance of where everything sat at the time, just to make sure that it was robust and safe as it possibly could. So to give an overview, this is probably where we are, the National Bed Tracker. So 100% of all the care homes in Mid and South Essex are now on the Bed Tracker. 73% are uploading their information on a 72-hour basis. So there's a vast improvement, but we do have a way to go, but we're working with everyone to do that. And I said with NHS Mail, and that's now 83% of our care homes are now online with that. As with that, there's been some complications in that some of the email addresses are very long, and we're working to see what we can do with NHS England to refine that. The quality queries line have received 320 calls, which we have dealt with, and they were themes of infection control, in safeguarding, and quality queries, which we addressed, and that care home line was open 7 days a week from 8 until 8. As part of my role in Brentwood and Basildon, I was keen to kind of know exactly what was the need. So I undertake personally telephone interviews myself, going, well, now that actually and this was literally a little bit after the hiatus, was what do you need now? What do we need to look at? So what they told me was, actually, they wanted care plans that was to help them to monitor. They wanted to be clear on the offer and to use digital tools that can be effective and need less visits. But it was important that we kept the resident at the heart of what we did, and to improve the use of monitoring, verification of death, and have empowerment of our roles. I saw Jackie had her hand up, but I'm sure we'll come back. So obviously on the education and training agenda, this is what we've done over the last 3 months. So training and education to ensure that dignity at the end of life, it was important that we skilled where possible care homes who had nurses, our community nurses and nursing homes. And so today, we have 72 more staff in the system that are able to verify death. In terms of infection control, we took the call for offer from the Chief Nurse of England, where we offered 307 care homes training in infection control. Now, this infection control was to improve empowerment for those care homes in donning and doffing, a whole new different ball game. 70% of this was done face-to-face, 15% was done virtual training. Of those that declined already had training set up, but to ensure that we all were disseminated with the same message, the same videos and posters and videos were hand delivered and we emailed the public health videos to those as well, so it meant everybody was off the same message. We did baseline observations training, which we're rolling out at the moment, and that's through the Prosper quality team, who've been amazing during this journey. And next, we created for informal carers at home and in care homes, Significant Care, which is a tool to help and empower care workers to monitor deterioration. In terms of the monitoring deterioration aspect, this was based on the guidance that was produced by the British Geriatric Society, and that was issued on the 19th of March. As part of that scope, we rang and contacted all the care homes to undertake what skills they had, what equipment they had, and how they were monitoring deterioration. We've heard that some did not have any equipment at all. Some that did have thermometers were still taking temperatures auxiliarily. And we also ascertained what areas had Wi-Fi, etc. So based on what we'd discovered, we put a business case together, and we were able and are in the cusp at the moment of creating a digital platform through the skills of WISM, which is a blood pressure pulse oximeter that the portal interprets the readings for care home staff, because we know well they're not clinically trained, not all of them, and the portal looks and is able to triangulate those results and target what needs to be done, which really empowers the carers, but also gives GPs and nurses a lens to be able to ascertain exactly what is wrong with the resident in the care home. And the next thing that we've been looking on, probably guidance that has come out, and as you say, there's been plentiful as part of our care sector group as well. As Melody said earlier, the guidance were coming out quite thick and fast. They were very weighty, and we set up a reading group to be able to come out with the highlights that we sent to the care homes, and we did that through the community strategy. So the next thing we looked at with primary care was how would we look at the tiers and escalation to support the care home resident. So what does that look like with care plans, WISM, case management, and the identification of having a named clinician per care home, which is all in hand now, and in aligning the care homes with the primary care networks as well. Individual care plans was now in preparation for winter will be taking place as well, which will place baseline observations based on the data that we're collecting from the WISM. And finally, as with all these things, is communication has been our key, with working with all providers and building the bridges to where we needed to go. And the community station, I don't know whether the link will work through this format at the moment, but we've highlighted a booklet of all the work that we've done in this time. So whether it's disseminating robotic cats to care homes, to twiddle muffs to help with patients, especially when in terms of isolation and how they manage that, and the guidance, the revised of the guidance, and we have produced 11 summaries, our weekly newsletters to the forum based on the work that we've done and the highlights and the messages that they needed to know during this time. I'm happy to take any questions when necessary.
Okay, Geraldine, thank you for that. I think I'm right in saying the way we've set this up is that questions will run through the chat function.
Okay.
For those of you who haven't found it, there's a little speech bubble towards the top right of your screen. So if it's okay, we'll do all the questions at not later than 4:30. But once you've found the chat, please feel free to enter your questions now if you would like to. I will keep an eye on that and aim to reflect those questions back. So, Geraldine, thank you again.
Thank you.
I'm now going to, thank you. I'm now going to introduce our second group of speakers from ECC. Melanie, in her presentation, mentioned how preoccupied she was at a certain time with PPE, and I know our next speaker will absolutely empathise with that. I'm now going to hand you over to Moira McGrath, who is the Director of Commissioning for ECC. Moira.
Thanks. What we're going to try and do here is a little bit of a kind of reflection on some of the work and some of our experience during COVID, and also try and do a bit of a look forward to the next few months, some of the things we'll be focusing on, both in terms of the next stages of COVID, but also how we want to work with you going forward as providers, and some of the key issues that we'd like to start to talk to you about as we're moving into the next stages. A couple of sort of immediate reflections on COVID. That a lot of the first stage planning that we put together was based on the flu pandemic plan, which was kind of had been in existence for quite a long time, and something that we as local authorities, health colleagues, would regularly practice, run sessions looking at scenarios around flu pandemic, and a lot of national planning again was based on that assumption. What became clear pretty quickly was that COVID was not a disease like flu. It was significantly more virulent. And that the challenges were very much at the high end of some of the scenario planning that we've been doing historically. So to some degree, we had to rip up that plan and start again. And I know that you as providers will have felt some of that. Again, just to sort of as a bit of background, what happens when we move into serious incidents or major issues for the population, the public sector system moves into what's called local resilience planning. So at the very start of the process, the Essex Resilience Forum was mobilised, which reached across all the public sector organisations, including the fire, police, coroners, etc., as well as health and social care, and the council as a whole. And that continues to run. So although that was meeting daily at the worst peak of the pandemic, but that system's continuing to run as we're starting to kind of move back to elements, a horrible phrase, of the new normal. It isn't back to where we were, as Melanie was saying. You know, we are going to be running with COVID for some quite considerable time to come. So we're trying to work through how do we manage some of the key things that we need to do, some degree of kind of opening up and normality, whilst we're still very much at the front line of the pandemic, which you very much feel on a day-to-day basis. One of the big challenges I think we had as Essex County Council in social care, and it's something perhaps reflect on as we go through some of the kind of thinking to the future. I think one of our biggest challenges is the volume of providers that we're working with in Essex. Talking to some of my fellow local authorities who perhaps had 10 or 20 providers that they're working with, compared to that, we have 410 homes, care homes in Essex. That's just for Essex County Council. That doesn't cover Southend and Thurrock, and something like 300 plus domiciliary care providers, plus a number of supported accommodation providers, day services providers, etc. And I think that probably showed in the way that we were able to engage and communicate with you. In the feedback that some of the kind of comments feedback that Simon has shared, we had quite a range of views. So a range of views from actually what we received was very helpful. We had good engagement, right through to I heard nothing from the council at all. And I think that is very much reflective of the challenges we have of building relationships, and more sustained relationships and longer term relationships with all the providers that we have in Essex. So I think we probably did at stages that we were in very much into transmission, so we were sharing a lot of information. I think getting some of that information back for you, particularly in the early stages, was probably challenging, and there's probably well, there's definitely some learning from some of the stuff that worked well, I think, as we went on, and some of the feedback that we had from you. So I think that's something that I reflect on about those ongoing relationships and sustained relationships between providers and the council and our NHS colleagues. I had the, I'm not quite sure what I did to offend anyone, but I was asked to take a lead on PPE at the start of the pandemic, something I sincerely regretted volunteering for, because it was an inordinately frustrating process, some of which only is reflected, so I don't intend to kind of go over that. Just to say that we, in the early stages, we shared a lot of frustrations of the sector. It was incredibly hard for you and for us to get hold of PPE, get clarity on what was coming, when it was coming, when we started to get drops out from the NHS and the Ministry for Local Government. The other deep frustration for us and health colleagues was we were getting most of the guidance at exactly the same time as everyone else. So we dreaded the hearing the broadcast at the end of the day, because we knew there was a huge amount of work to kind of understand, distill and try and make sense of the guidance, and particularly the guidance around PPE, when we were expecting significant changes in use of PPE when we knew that PPE wasn't available. What we were able to do was mobilise quite a significant team of people within the council pretty rapidly to start to work on access to PPE, and we, as you know, have bought an enormous amount of PPE. So to give you some sense of the scale, we are well beyond having issued 1 million items of PPE for our role as provider of last resort. And that's alongside the work that eventually happened around the PPE hub nationally being set up. And that involved us really from scratch going out sourcing, identifying providers. We had over 300 suppliers contact us, with some that were very helpful, some that were were implying that they had PPE, but we had to work through all of those offers. We obviously sought businesses to donate PPE, and we're able to get some of that out to you. Not all of it obviously was suitable for use. So in the background, there was an enormous amount of work going on. I think we've now got to the point where, so we have created a significant stockpile of PPE. So our role as provider of last resort, that will continue, and we will continue to run that until any of the national systems are supporting all of you, which obviously for the larger providers are not yet able to access the PPE portal. So that will continue into the future, and we will continue to build that stockpile because we are concerned about any future kind of dips in availability of PPE. And I think one of the big lessons for me was that the national stockpile of PPE was held at one place in the country, and the logistics of getting that out was really significant. So even though there were 24/7 collections happening and deliveries happening to local systems, that wasn't keeping pace with the demand, as you know. So there's some really significant lessons there to think about the next stages of COVID, but also what we might need to do into the future and the role of local government within that. We did a lot of work around, we did some very rapid work about trying to get some financial support arrangements out to you in the first couple of weeks. That went into place, but I think with the daily information that we were providing to you and the weekly webinars we were doing, it was clear from some of the feedback there were some gaps in that. So we did make changes to that probably about a month, 2 months in, and then obviously subsequently the infection control money came out from the centre. So I think there was some learning about the kind of initial work we had to do and what actually worked for you, and we're still getting feedback about how we can make some of those processes easier. So we're continuing to adapt and refine how that's working. Again, it's probably working for some providers, not all providers. So we're trying to get a bit of a happier medium there. If I can just, Curtie, if you could move on to the slide around the care home hubs, just to slightly go out of sequence. So I think that's it. Thank you. So our operational teams and our quality teams did an enormous amount of work, which Geraldine has touched on already, working very collaboratively with CCGs to create care home hubs. That enabled us to have, I think, much more localised and direct contact to resolve issues, give advice and support, and particularly support homes that were experiencing outbreaks. So having got that running, I think this has been, we think, one of the more successful elements of the work that we've done. We were able to redeploy the quality team, so Sam Crawford's team in ECC, who normally go out and do quality visits, training and support, were redeployed into providing direct support to care homes and working through guidance, looking at issues around PPE and collectively working with the NHS around infection control. I think we've had good feedback that has been really helpful, and we think that really helped with a more day-to-day contact and a more tailored and targeted support. I would want to echo the comments about the tracker. The tracker, I think, has been immensely helpful in getting timely information. We do look at it. We look at it very regularly. It's helping us with our capacity planning, and it's helping with the day-to-day planning and to identify who needs perhaps more support and contact. One of the areas that came out strongly from some of the early webinars was the challenges of supporting people with dementia in care homes, particularly with the restrictions that are in place. So we're able to look at additional support around that, as well as a range of different things that providers were asking for. Kurt, if you move back up 2 slides. Thank you. Sorry, move on to the care home slide. Next one. Thank you. So just to think about the next stages, and Steve will talk about this a bit more. We're thinking about what we need around care homes support going forward. We have seen obviously a significant reduction number of people in care homes as a result of the incredibly sad deaths that we have seen in the sector, but this is also part of a longer term trend about more people choosing to live at home or stay at home for longer than perhaps they would have done historically. We're working closely with NHS colleagues to look at our current supply and demand within the sector. We think we need to look at different more specialist elements, so particularly dementia care and support, and develop some of the training, some of the more specialised elements of dementia support across the county. Look at the balance of long-term versus temporary beds, look at areas like end-of-life care and improving the quality of end-of-life care. And we recognise that we need to look therefore at issues around pricing, issues around support going forward, and what the right health and social care wraparound support for care homes in local places should be. And the other bit that we started work before COVID, working with ECA and other colleagues in the sector, is around workforce. So there's been a regional workforce strategy developed, which we're aiming to share with you fairly soon. And in the very short term, across the care sector, we're also looking at social media campaign to support recruitment, particularly encouraging people to come and work in the sector within Essex. And we want to link that to the end of furloughing, because we believe that it is an opportunity to attract more people to work in the sector. We're developing our independent living approaches. So even over COVID, we've been continuing to mobilise some of that capacity, and we will have new facilities opening over the next year. And the other thing that, again, Geraldine talked about use of digital technology and some of the kind of different opportunities for communication. We used COVID to test alcove units, so they're communication units that enable individuals to use tablets to connect with loved ones and potentially with health and care professionals. So we've been testing some of that out, and we've got a broader approach to technology. So I'd be really interested over time in your views about how we might use technology differently to support people, what direct support we need to give to homes to make that happen, the kind of investments that we need to do across the council, and potentially linking with health colleagues as well, using the kind of examples that Geraldine's described. If we move on to the next slide. Sorry, and next one again. Thank you. Sort of slightly out of sequence. The next piece of work we were working on prior to COVID and had done some really helpful engagement with a number of care providers supported by ECA, is to look at live at home, so our domiciliary care services going forwards. Again, there's really strong appetite for our CCG colleagues to work with us on this, to focus on how we support people to stay at home, which is what a lot of people want to do. But going back to what I was saying about the number of organisations that we are trying to work with, really to try and refocus on a much more local support offer that enables providers to work more closely with health and care colleagues, including GPs, in a local system to plan for a population. So as part of the next stage, we'll be looking at more localised test and learns, particularly in areas where we've found it harder to source or that are less attractive for providers to establish in. And we think that requires us to work to set up different contractual arrangements, but also arrangements that give more flexibility about how to support. We want to encourage more people to use direct payments, and we're interested in testing options around micro provision, and we're using some advice and support from national organisations like Community Catalysts and Think Local Act Personal in setting up a range of different arrangements that may be attractive to you or for carers to come together as personal assistants and offer a much more kind of hyper local support around cohorts of individuals. So we'll be talking to you more about that. We had a webinar a couple of weeks ago where we went through it in much more detail, but we continue to be really interested in your views about how we develop this. I think there are challenges around the procurement process, and when we actually initiate that, we'll be taking paper to Cabinet to get approval to move ahead with this, but we will be taking views about the appropriate time to actually launch the next stage procurement process, because we want you to be in a position to respond effectively. Steve, do you want to pick up from here?
So you'll be pleased to know I'll be brief, conscious you've been listening to people for a long time already. So for those who don't know me, I'm Steve Eade, I lead the procurement team. And I just wanted to quickly end by talking about some market shaping work that we're just starting at Essex. So this slide just kind of frames what we're trying to do, and hopefully none of this would be a surprise to anyone. So it's about promoting local choice and control, promoting local communities, all that sort of stuff. But what it actually means in practice, as Maura touched on, year on year in OP residential, we've seen a reduction for many years now of the number of beds we've used. So to give you an idea of scale, Essex at the start of this year had about 4,200 older people's residential beds that we purchased as a county council, which is about 35% of the market. And in the previous year, that number had reduced by about 500. So far this year, the number's reduced by about 700. Which is because of the number of excess deaths caused by COVID. So that's caused quite inevitably quite a bit of stress in the market. So overall, we've seen void levels increase by about 10% in the market, but clearly that's impacted some providers much harder than others. So we're now starting some work, which we will absolutely be engaging ECA and the broader market about, how we work with the market to take out some of that capacity, and at the same time look to increase capacity in those parts of Essex where we still have an undersupply. So again, the overall picture is we have more beds than we need, but in some local areas we still struggle for supply. So in the weeks and months ahead, we will be developing a policy to inform what we do going forward, which clearly will need to have political approval. And at the same time, in parallel with that work, developing some plans about how we can support homes in the short term, because we already know that some are already in distress. Moira mentioned a range of financial support that's already in place and has been in place for some months, and some work's being done at the moment to accelerate the delivery of some of the claim fund elements of that. So I do appreciate, and there's been some questions already, that some of that's been slower than we had hoped. But that basically is because we've had many more claims than we've been able to deal with. We now have significantly more capacity in the team that's processing those claims. So hopefully you'll start to see that money drip feed out to you much quicker now. Also, part of the long-term trend we're seeing is a switch towards domiciliary care. And so far this year, we've seen our volumes in dom care increase by about 8%. And we anticipate that number increasing more as we reduce our use of residential care. So again, part of what we're trying to do with our new contracting approaches for domiciliary care is to help support that part of the market to grow. And at a detail level in there, domiciliary providers will be aware that for the last winter period, we introduced an incentive payment to encourage providers to take up packages over the winter period. That payment is still on offer at the moment and will be till September at £500 per package that's on our unmet need list. And we'll be looking to go more formally to the market to get some views about how we might replace that for the coming winter period with something perhaps a bit different that might be more successful, I guess, being blunt, at getting some extra capacity for domiciliary care as we approach the next winter period. That's all for me, so I'll hand back to Simon.
Thank you for that. So quite a broad, Moira, thank you, overview from our speakers there. Some of it about the more personal individual elements of it, some more about the market and the way that's going. The way we intend to conduct the next half an hour or so is through Q&A to primarily to the speakers that you've heard, but also I will welcome Simon Froud individually, who some of you will know, Director of Local Delivery for Mid-Essex, who's particularly going to respond if there are any operational issues. And I know there are one or two other ECC people in the audience as well who may be able to respond. So I'm going to take the questions in the order that they've been asked and invite the panel as a whole really to respond to them. But I will try and group things up where it seems to make some logical sense. So and just to say, if people haven't yet found it yet, in the middle top of your screen there is a little toggle button that allows you to switch between viewing everybody, viewing who's speaking, etc. So if you find it less distracting to view who's speaking, that's where you need to look. Okay, so to start off with questions then, got a couple around training. One was asking about the availability of training for verified acts, and also about training staff as phlebotomists, which is linked to training. I wonder if our panel would like to respond to any of that.
I think that's probably for Geraldine and Sam.
Yeah, I've just managed to unmute myself. Thank you, Moira. So regarding the verification of death, so I think in the space of a week, we ended up having 2 versions of the guidance that came out on verification of death. And it needs to be a fully clinically qualified person to be able to verify death, because you can imagine this is a huge responsibility, and one I've done myself on many a time, and not to be something that's taken lightly. So So the training that we got St. Luke's to work with us to set up the training. So we've got more people in the system to be able to do verified death. The training is still open, so anyone who has a clinical background, etc., and wants to speak to us, more than welcome that conversation, and we can get you in touch with St. Luke's, who offer the training for Mid and South Essex, and Farley Hospice is looking at it for Mid. So happy to look at that. In terms of phlebotomy training, again, probably the same skills would apply, but I think as we get more and more, I think the whole idea is it's fine getting people trained, but if people aren't having blood all the time, it's getting the competencies. So doing the training is fine, but building up the competencies to be able to do the blood. And sometimes you might just have 1 or 2 persons a week or a month. So sometimes getting the competencies would take longer than you would possible. But I think if there's a need and there's a huge cohort out there, I might say is nothing is impossible, and if there's a need and a hunger to do those things, I would certainly explore it and see what we could do to make that a reality. But I think it would be the community teams we utilise now, etc., to help with that cause too.
Okay, Geraldine, thank you. Melanie, I was just going to come to you because we mentioned phlebotomists on the national call earlier this week. I wondered if you wanted to say something about that.
I think it has been left to local, Simon, but I know that with the rollout of antibody testing, one thing that has proved quite useful is to maybe review the competency of nursing home staff so that they can do the blood tests for the antibody testing rather than putting extra strain on NHS resources.
Next question we have, perhaps again for Geraldine, is about whether there's a platform for dom care providers to discuss concerns, get training and updates. I don't know whether the person asking the question was thinking perhaps the ECC have a provider portal as a go-to source. Do the CCGs have anything?
Well, normally all our providers that we would commission, they get in daily contact, well, as in when as they need support, they email us, and during COVID we were doing weekly emails with them just to check and see how they were. So and different CCGs will have different providers that's allocated to them. So it's a different offer because they will have their own governance bodies, etc., than what ECC would have. So it's a different function. But okay, we're there to provide support.
Okay, thank you. Our next question, this might be going into a bit too much detail, but perhaps signposting would be useful. Someone living with dementia in a care home is known to wander. Where do people get advice on, I suppose, how best to contain them in a safe and dignified manner, given the COVID pressures?
Sure.
So there's go on, Geraldine.
That's fine. We had linked with our dementia colleagues, and through the newsletters we have issued different leaflets and guidance. We also got those care homes who were worried about those for infection control to speak with them till they were able to know what to do. And those that are very complex, what we've done is, because obviously you don't want to restrict anyone's it's because we need to be respectful of everybody and respect their independence. And for those, we come up with innovative approaches to help support them in that isolation period as well. So that's where the robotic cats come into life, or the twiddle muffs, and individual care plans, and the dementia crisis team from a health perspective. But I'll hand you over to Moira to get her perspective on it.
So
Simon, yeah, Simon's he's waving.
So I think Geraldine's right that we have specialist dementia teams and services that could give advice and support on how to support people in different types of care settings, certainly care homes. On a couple of occasions, I think, and Sam Crawford's on the line, I think, the care home hub advice when they meet can give some different bits of advice. I know on occasions where I've heard if there is a few residents who are asymptomatic or positive or and have certain sort of needs, certain parts of the home have been isolated off. So if there is a lounge, if it's possible, and this might not be possible in all of the settings, to enable that person to wander a bit more freely. Sometimes the use of outdoors as well is sometimes used, but that is obviously a difficulty and a risk sometimes. But so it is really dependent on each individual type of home and service.
So, Melanie, did you want to respond?
The other thing to do is this is sometimes somewhere where volunteer help can be really useful, particularly if you are going to perhaps go outside or put in activities. The volunteer bank that the NHS put together has often been useful in situations like this, provided that people can be trained or educated to make sure they're going to be able to do this safely. But if it's someone who likes to do jigsaws, likes to talk to people whilst they're wandering, or moving with purpose, sorry, the volunteers are quite a good resource to call on.
Thank you, Melanie. The next couple of questions to do with payments, delays in response, degree of frustration about emails and so on not being followed up, but somebody waiting for their second payment with the Infection Control Fund. I know colleagues from ECC can't respond to individual cases, but I wonder, what should people be doing in this situation if they're having delays? How can they address that with you?
So on the second payment of the Infection Control Fund monies, so we've released about 55 of those this week, and those second payments will be released to care homes once they've submitted evidence that they've spent the initial allocation. So that's the process that we've agreed, and like I say, we've already started. So some homes will already have received money, and others will. That money's on its way. In terms of the more general question, I did mention, Simon, during my piece that we have had some delays in processing claims, which I apologise for. So to help address that, we have worked to simplify the process both for providers and to simplify the checking we're doing internally. And in the last 2 weeks, I've brought in more capacity to my team, significant additional capacity into my team to process those claims. So I am aware that there's a backlog in that piece of work. And like I say, the additional capacity is now in the department, has just about been trained now. So hopefully the market will start to see more responses come out quicker. So like I say, we had many more claims than we anticipated getting, and they took longer than we'd hoped to process. So that's generated lots of correspondence with providers, lots more than we expected. So like I say, I apologise for that, and we've taken some corrective action. If you're still struggling, let me think about. I don't want to just give out an email address and then find that someone else just gets inundated with duplicates of emails that have already gone into the team, because that will actually slow things down for everyone, is the reality. But I'll give some thought to whether we could introduce some sort of escalation process or something.
Thank you, Steve. That's helpful. I'm just going to jump further down because there's another question that links to it, and one of our audience is asking about really there's extra bureaucracy required to fulfil the requirements that you've put in place and referenced to, well, and not all authorities did it that way. I think I know something about the constraints that you're working under, and could probably answer the question for you. But I wonder whether Moira or Steve, you might want to say something about the process ECC has put in place around IPC monies, and Melanie may even have a national perspective on some of this.
So for the infection control monies, the reality is, unfortunately, that all of the restrictions we're passing on to the market are restrictions that have been imposed on Essex. And the reality is equally that Essex is liable for any money that's spent inappropriately. And the expectation is that the process we've put in place will be audited, and that Essex will be liable to repay any money that we've shared with the market that isn't consistent with the controls and the guidance that have been put in place. So hopefully you appreciate that because the liability rests with the Essex taxpayer, we've had to put in place some controls which are much more stringent than anyone in Essex would have liked. But that's just the reality we find ourselves with. So it's unfortunate, but that's what it is. In terms of the broader claim fund process, Simon, we took a view very early on that it would be more appropriate to target support to providers that needed support rather than do a blanket uplift to everyone. So clearly you could argue the merits of that, but that was based on significant thought within Essex County Council, and we felt that that would allow us to be more generous with some providers rather than a lower overall uplift to everyone. And we still believe that was the right approach. And we have spent substantial amounts of money already out to the market to help them deal with COVID pressures. And I mean, if you look at our website, you'll see we've got a £12 million allocation to help support the market through that route. So, yeah. And equally, I think, as I've said to ECA before, if we get through that £12 million, I'm very happy to go back to the politicians to see if we can get some more. So we do absolutely appreciate that there's pressures on the market, and we're doing everything we can to try and help genuinely.
That's really helpful, Steve. And I know, there's certainly areas where I think ECC has been an exemplar in some of this that we've talked about. But what about the national picture, Melanie? Any reflections from you?
I think taking it in reverse order, the paying providers who need the money, I think actually in the long run has turned out to be the better solution for providers. The uplift seemed easiest, but that then meant that someone who did nothing extra during COVID was potentially going to make money out of the pandemic, which wasn't real. But also local authorities who went with an uplift, that's all there is. Whereas local authorities like Essex and like my own in Lincolnshire, where it was, if you need to spend extra money, we will help you, has actually proved beneficial in the long run. I know there's more bureaucracy, but it does prove more beneficial. And with the grant, it wasn't Essex, it wasn't even our government, it's the European state aid rules. Together with ADAS and the local government association, the trade associations spent bitter hours trying to negotiate something different. And eventually the guy from the Treasury just said, do you want the money or not? At which point collectively we said, we will put up with the bureaucracy because we need the money. So it is a challenge. It's a challenge for local authorities as well. If you think you've got a lot of bureaucracy as an individual provider, imagine what they've got to do, because they've got to fight it all. So just keep your fingers crossed that the next lot of money doesn't come out with similar conditions on it.
Thank you all. Okay, another, again, I'm jumping around a little bit to try and keep it coherent. In the case of somebody who may have an office outside of Essex but delivering services into Essex, my understanding is that that some people have claimed for what they're delivering for Essex people under the Infection Control Fund, etc. But in terms of an office outside of the county, my understanding is that's not an issue for Essex County Council, and that they need to talk to their own local authority. Is that the understanding of other colleagues?
That's
Yes.
right, and I think that there was flexibility in how different authorities used that 25%, so it wasn't mandated, it went to the domiciliary care sector. We felt that it was right because of the balance of challenges there were for both. So there'd been, in the first tranche was very much targeted on care homes explicitly, and different authorities are taking a slightly different approach, but if that individual contacts the relevant local authority, should understand whether they're able to make a claim to that area.
Thank you, Moira. We were actually able to help one of our members this morning who was looking to put in a claim with Havering Council, and through another member of the Care Associations Alliance could identify an individual there for them. So thank you for that. I'm going to group up next. We have some questions around hourly rates, which I think are primarily targeted at domiciliary care inquiries. So one of them is saying CCG rates are very low, and citing a figure of £14.81, and also can't immediately find it, but I think there was another question who's saying, well, ECC rates are lower than some other local authorities. And then the other one I just wanted to link in with that was that we had another questioner who was asking whether Essex would be taking into account the ongoing PPE costs going forward in terms of payment. So that's probably several questions at once, but I'll leave you to pick that.
If I take that in reverse order, so for domiciliary care, for PPE costs, our intention at the moment is that we will stick with rates that don't include enhanced PPE cost, and then pay an additional either rate per hour or rate per visit to cover the anticipated additional PPE costs for the duration of the COVID period. So rather than inflate all prices, we will seek to pay an additional element to cover the enhanced PPE costs caused by COVID. Hopefully that makes sense. And certainly my preference is that we do that in the simplest possible way. So that's what we're working on with the team at the moment. So my hope is that won't be a claim process. It will be a process that we calculate and pay to providers without any bureaucracy from anyone. So that's the intention. But we are still working that through, so we haven't got a final position on that yet, Simon. In terms of the question about our rates, I suppose the reality is our rates compare favourably to some local authorities and not so favourably to other local authorities. And in all cases, we have a range of rates available in each locality, and the reality is providers are free to choose the rate they want within the locality that they want to bid for work. And it's market forces, isn't it, unfortunately? So, in all cases, we do provide a range. Obviously, I can't comment on behalf of the CCGs, but
yeah. But thanks for that, Steve. Geraldine, I know you're not a commissioner, but do you want to respond to the perception that the rates are low with CCG?
I think those that's linked to the CCG would be linked to continuing healthcare, and all those packages are all done through an assessment, etc., and linked to that. So so I know it's all risk assessed and it's all needs assessed. So the fee would be linked to the identified need. And as you say, Simon, I come from a quality and safety perspective rather than a finance perspective.
Sure.
But everything is needs assessed in continuing healthcare, which would be linked to CCG. So I think it just might be if I'm not sure whether that question is linked to continuing healthcare, because that would be the only thing that we'd be paying for from a CCG perspective. So just probably clarity on that angle if I was to help, because I'd need to forward that on to the finance department if it was a query.
Sure. So, Moira, did you want to say anything? Or I've got a very small picture. That's fine. That's fine. I've got a very tiny picture of you, so that's fine.
I think all let's just say on the CCG is that we are looking to CCG is keen to work with us. So as we're thinking about the kind of future for live at home, we'll be talking to CCGs on an ongoing basis, because we're trying to look at the demand and capacity it makes sense to look across health and care. So we're working with the sector, you know, in partnership, and the kind of rates and the way that some of those contracts work is all, you know, it's all interlinked, I think.
Thank you for that. I'm conscious of the time. I'm going to do one last question, which is around tests. But before that, I just want to say what may not be visible to everybody is that ECA are having regular conversations with Moira, with Steve, with other ECC colleagues. And one of the things that we regularly do bring up is the sustainability of the sector and the finances. So we recognise that ECC have got significant financial constraints at the moment. We will keep having those discussions about costs and rates, etc. It's a regular part of those discussions. So bearing in mind the time, the last thing I was going to come to was that there had been a couple of questions on the chat about accessing tests, lack of availability, particularly are they likely to become available more broadly, perhaps for extra care and supported living. I don't know whether anyone on our panel is able to respond on testing and availability thereof.
So I can probably kick off. The colleagues might want to join. So the national testing isn't being run by the council. So we're kind of we're the messengers here, not running the process. So clearly there has been a delay in the rolling out of the regular testing that Melanie was talking about to care homes, and it was started with care homes, and the intention is to roll it out more widely. But until that care homes process is properly established, I think there will be some delay in that coming to domiciliary and supported living providers, and we're waiting to hear as you are, so we'll pass that information on when we know it. I think there's a question in the chat about a query, a member of staff that has COVID-related illness and seeking tests. I think in those circumstances you should contact Public Health England and try and seek a test through the local processes with Comissio. But if you contact Public Health England, they should be able to give you advice on that, and I'd suggest doing that pretty urgently.
Just to follow on from Moira's sort of comments, to say that the care home hubs also sometimes get questions of this on a localised basis. So, and they have Public Health England, Health Protection Agency, and other colleagues, and our DPHs as well, or reps. So, if there are local questions and issues, then they can get advice on that care home hub bit. The other sort of thing just to mention is that we are, and it's not sort of concluded yet, but we're looking at antibody testing as well with our CCG colleagues for the residential staff and with care homes, the staffing in particular. But that's not coming out just yet. So I don't want to raise any expectations, but that's something that's in the pipeline.
Simon, thank you for that. Melanie, over to you, I think, for our final response.
I think, yes, it would be good if it was being rolled out across the rest of the sector as originally intended, but the testing is being done on a risk basis, and the risk is perceived to be at the moment in care homes for older people. And because of the delays in those testing, my feeling is that those tests need to get done first, and then we'll go back to the programme we had originally, which was older people, then residential, then domiciliary care. Because at the moment, the spread of the virus within people who receive packages of care is more or less the same as within the rest of the community that they live in. So there isn't a perceived need to have tests, but I understand that that makes it more anxious for providers and care staff, but it's very much being done on what is the need, and the antibody testing, which will come soon, will give a different view. It will give the view of what was the prevalence in your area. So I think that the regular testing of certainly of domiciliary care staff is some way away, because it's also logistically, it would be a nightmare. It's not like a care home where you can do them all at the same time. So I don't think that's going to be anytime soon. But be reassured by that, because actually that means that nobody in Public Health England or the SAGE committee have decided we need to do that urgently.
Okay, thank you. And did you also want to make a quick comment about the chat around the PPE portal as well?
Yes, the PPE portal has been, as Moira confirmed, it's been open to all providers. it does say on the introduction this is for emergency supplies only, but what that means is it's not going to replace your normal business as usual supply. But the request from the PPE group this morning was please register, please order, because what they want to do is resilience test this while it's not essential, to make sure that that supply chain method would work for the whole sector should they choose to go that way. And the other good news is whatever you order from the portal is free. No cost to Essex, no cost to you. It's free from a national government pot. And it's not a huge amount, but every little helps. But please try it, because the key thing is we need to be sure that it is going to work if every provider is using it and isn't going to fall over.
Melanie,
just on that, so ECC will continue to act as supplier of last resort until we're really confident that that system is completely working and is able to be resilient, as Melanie described. So we'll people can still come to us if they're having supply shortages.
Thank you, Maura. Thank you, Melanie. We're slightly over time now, so thank you for all those questions. I'll now hand you over to Clive to thank our speakers. Clive.
Well, yes, I mean, I'd like to thank our speakers today for supporting our conference. I mean, it's been very much appreciated. We've had some fantastic conferences over the last few years, and whilst having a conference like this isn't perfect, I think that we are all becoming a little bit more comfortable with video communication and accept it that it's the best that we can do whilst this pandemic prevents us from meeting. But I suppose one positive is that it means we don't have to travel to a venue. But even so, I hopefully look forward to meeting you face to face at our autumn conference. So thank you everybody for joining us. And on that note, have a good day or have a good week.